Hi, and welcome to the Shoulder and Arm Health channel. I'm Dr. Roger Sohn, and I've got with me today Dr. John Thomas, who's a physical therapist and the owner of Laguna Orthopaedic Rehab. Today we're going to talk about physical therapy, and specifically we're going to talk about how it relates to shoulder conditions and how does physical therapy work in general. So, John, good to see you. Thanks for coming on the show.
Thanks for having me. Good to be here.
So, John, you've treated a lot of my patients, and we've had some good successes from physical therapy. So, in general, when I send a patient to you who has, say, bicep tendinitis, what are the first things that you're going to do to try to help that patient?
Definitely try to develop patient rapport, hear them, hear their story, and then take them through a physical examination. Try to see what we can do manually or use of modalities to calm their symptoms down. But then ultimately, what can we do to prevent it from returning?
Okay. Now, earlier when we were talking, you were mentioning some of the issues people have, which is that you take patients through an exam where you kind of see what kind of mechanics they have, or if they have bad mechanics specifically. Tell me more about how that works.
Absolutely. Typically, even with biceps tendinitis, a lot of times we see posture as being a problem in terms of causing them to move awkwardly, which then places stress to that biceps tendon, which then causes the inflammation to occur. So going through a pretty thorough examination of posture and what structures could be tight or weak to result in the way they might be moving.
So in the case of like bicep tendonitis, what structures do you usually see as tight in the shoulder that is maybe a root cause and that is in a common scenario?
Right. Definitely tightness in the pecs,
Okay.
which then causes them to be rounded. A lot of times tightness in the spine in between that shoulder blade area, which then prevents them from sitting upright. And with muscle imbalances are very typical, which result in poor postures.
So would you say that like people are working out the wrong muscles? Like in the gym, I always see people doing the bench press, and is that part of the cause of this? Is that why you see this? Is that to blame?
That's one of the causes. Another one is just we tend to sit poorly throughout the day, or we have a job that requires a lot of driving, or a job that's sitting at a computer, or we eat, or we sit and watch TV, or we sleep in a fetal position.
Yeah, yeah.
So those all reinforce that rounded position.
Okay. So you would say in more cases you see the shoulder blades slumped forward, and you're trying to correct that by bringing them back. Is that right?
Absolutely.
So yeah, and I would definitely echo that. I see that myself when I'm typing in front of a computer. I
Right.
tend to sit with my shoulders hunched forward. I have to really think about like my mom with a ruler trying to slap me on.
Right.
Basically saying
Right,
you gotta
right.
sit with good posture.
And a pretty interesting wake-up call we do is we have the patient sitting slouched and we say, yeah, raise their arms up. And then we have them sit upright, and you guys can try it at home, but a lot of times your shoulder moves higher with less pain
Yeah.
if you're in a good position, and that
Totally.
drives home what we need to then correct for them to get rid of the pain.
Okay. So posture is an important part of all of this, it sounds like. But I guess in my thought or in my head, I often picture patients going to you and they're doing a series of exercises and trying to induce a change in their actual tissues, like their muscles or their tendons or even ligaments.
Right.
Is that really what you're trying to achieve, or is that sort of a happy byproduct of some of the things that you're doing, or what's your philosophy on that?
So if the tissue irritability level is up, we want to do things to bring it down. Sometimes those things entail hands-on therapy, soft tissue work to try to improve blood flow to that area to help reduce the inflammation. When the body's in pain, things tighten up, so we might have to do different things to reduce the stress to those areas, so then you can go into a good posture and you're not playing tug of war. So a lot of it is identifying the structures that are restricted, whether it's muscle, fascia, joints, nerve.
Okay. So give me some theory on how it works to like get things to loosen up. So let's say I've got a tight pec muscle here and I've got shoulder pain and I can't reach up because I'm, so drawn forward. So what are you trying to do in order to get that muscle? Is it just stretching? Like, do I just need to stretch that muscle, or are there other things that you're doing to actually lengthen the muscle? We've talked briefly about some of these other maybe fad type things, such as like the pliability things. exercises that you hear Tom Brady and others talking about. Like,
Mm-hmm.
are you actually trying to get that muscle to grow or to lengthen, or how does it work?
I think in the beginning, we definitely want to reduce the inflammation or the tissue irritability level. That could be some gentle things to improve the fascia mobility, because the fascia basically is like an envelope around the muscle, and if that's tight, that will prevent the muscle from moving like it should. So reducing that, and often when the irritability level goes down, you can get a little more aggressive with maybe some other techniques where you're really trying to work on lengthening a muscle if it is shortened.
Okay.
Sometimes it's just in that position because of pain, so they're guarding.
Okay.
A lot of times when we reduce the pain and then show the person where they need to be, sometimes then it's just retraining that motor pattern. Yeah.
Okay, retraining. Now I've seen and I've experienced some cases like of where people are scraping the fascia.
Right.
I'm not sure if this is something you folks do in your practice, but like some people call it ART, active release therapy, or the scraping or Graston techniques. What does that actually do to the muscle and fascia, and what's your take on that sort of stuff?
I think it's a good tool to have for the toolbox. Obviously, you have to be careful when you use it, because if somebody's really hot and irritated, they wouldn't be able to tolerate that type of aggressive treatment. But if the irritability level is low and you're trying to restore some mobility and you feel like scar tissue or tight muscle is preventing that shoulder from reaching overhead, yeah, I think that's a great tool for the toolbox. And a lot of our physical therapists at the clinic utilize that.
Okay.
Yeah.
What are some of the more common things, like when you see a patient and you kind of prescribe them an exercise and therapy routine? What are some of the things that are your go-to, like exercises or stretches? Like, what are your best tricks?
My number one, and I feel like I do this with everyone, whether they have shoulder pain or neck pain, is try to improve the thoracic spine mobility. And that can be with manually done, where I'm using my hands to try to get those joints to move better. Lacrosse ball, having somebody lean into the wall and find those little areas that are stiff, because as the shoulder moves up, those joints in the spine move and the shoulder blade also glides. And if there's stiffness there, that can affect the mechanics. So that's a big one to me. I feel like I'm always working on the thoracic spine mobility.
Okay.
Yeah.
And what else would you say, aside from the thoracic spine, in the shoulder itself, like what are some of the exercises that are like, I remember you treated my shoulder and you taught me those plank taps. I don't think you just call them taps.
Right.
But for me, that was a really good one. But is that something you still use, or are there others that you find really useful in the shoulder?
Absolutely. No, and this is where a good physical therapist will kind of tease that out, so it's more of an individual-based program. Mm-hmm. But with that being said, everyone gets exercises to strengthen those muscles in between the shoulder blades. The rotator cuff muscles that help support the shoulder, because if they're not strong, they basically keep that ball in the socket. And if they're not strong while the person's moving their arm around, that can alter the mechanics. So definitely rotator cuff strengthening exercises, mid-back strengthening, and then like you were talking about the plank, that really works on the core and all the muscles that stabilize the shoulder.
So great. So, obviously you have many tools you have many tricks up your sleeve. You have many tools in your tool belt. So I don't want to ask you to try to recreate everything here.
Right.
But I think in general terms, I'm interested in knowing, there have been many trends that have been trending on the internet and YouTube.
Right.
So for example, you've probably heard of the knees over toes guy.
Yes,
I'm going to try to get your reaction to one of his videos here in a bit.
Okay.
But you've also heard of like Tom Brady, the TB12 method, and they talk about pliability.
Yes.
A lot of this, at least as far as I can see, seems to be very similar to like active release therapy or at least fascial scraping, the type of things that they're trying to achieve. And I guess my thought is, or my question for you is, do you think that this stuff really works? Is it just a repackaging of something that you already do? Well, so why don't we go to that knees over toes guy?
Okay, so the guy's sitting back onto his heels, kind of going towards the floor, and then contracting the quadricep muscles to help pull himself back up. And then he's going through a little progression from a higher surface to a lower surface.
I mean, to me, it looks very uncomfortable. Like that knee is flexed like 100 and
Yeah.
170 degrees, and he's asking the quad to basically fire from that position. Like, do you think that's valuable or is that dangerous? Like, are people going to hurt themselves?
I think there's potential for injury, of course, and you would want to do this very safely and maybe have a professional walk you through a little bit of that so you don't hurt yourself. But there is, I can see the value.
Okay.
For sure, yeah.
So, like, when you see that, I'm going to pause that right there.
Yeah.
So, what you've seen so far, like, what do you think that's accomplishing? Like, is that something that, like, when I see it, I see someone who's putting the quadriceps muscle under, like, maximum stretch. And then they're asking that quadriceps muscle to contract or to do work. That's not usually the way we exercise. Usually we're exercising in the mid-range. So if I'm in the shoulder and I'm doing like a deltoid thing, I'm not going to be like starting with my elbow basically across my body.
Right.
So what is this doing, and how in terms of the shoulder, like how could we harness that if it is a good thing?
Right. No, I think the first thing that comes to mind is and this is old school, contract, relax, using the PNF pattern, where basically if you're trying to...
What's PNF for our viewers?
Proprioceptive neuromuscular facilitation.
Okay.
So for using the hamstring as an example, if somebody has a tight hamstring and I take it up to that barrier where I feel the tissue tension, and then I have them push into my hand, now they're contracting the muscle instead of it being lengthened, which tricks the brain, so allows those protective sensors to say, hey, I don't like being stretched this much. Now it's contracting, so it tricks the brain, and then they relax it, and you can take it further.
Okay.
So that's kind of taking
sense.
that principle to another level, which is, I'll have somebody lying on their stomach, and I'm bending their knee back, and I feel that barrier, and I say push into my hand, and then they push, give that contraction, then they relax, and I take it to the next level.
Okay.
So this is kind of a way where you can do it on your own without having somebody do it for you, but you got to be wise with how you get into that position, because just sitting onto your heels for a lot of people, that requires good ankle mobility, good joint mobility, good muscle flexibility. There's a lot of things you need to have, but so you don't injure yourself.
And you need to not have arthritis to do that.
This is true. That will put a lot of stress on the joints.
We'll get a little further reaction as this. Let's let the video play a little bit more.
Right.
So it looks like he's basically making the exercise easier by basically raising the heels so as to still achieve that angle, but not requiring he's about to do this now where he basically goes to a full, gravity, no assist against gravity.
Yeah.
So he basically gets all the way.
That's really loading up those quads for
Yeah.
sure, and a lot of other structures, which not many people can do that. But I think if you go slow, you may be able to build up to it. And I think I do remember seeing this before. He did say, maybe once a week and be very cautious as you get into it.
Okay.
But some people think more is better. And, and there's always, and I'm sure you see it, patients Google different things. And so they come in with a lot of ideas or maybe things that they've already tried, which could potentially worsen the situation. I do think it's a tool, but it's got to be used with caution, I guess. Yeah.
So I mean, I send you a lot of patients who have bicep tendinitis.
Yes,
so I see a lot of patients with bicep tendinitis.
Right.
And so I'm not sure you are working on many other things, but is there some way that we could harness these kind of ideas of like pliability or lengthening muscle units to actually to exercise the bicep in such a way that there was less tension in it? I don't know if that's possible to do that and create less tension for more than a few minutes or something like that. But is this something that we could be exploring as designing a new exercise, for example? Yeah,
absolutely. And I think, or even just taking those principles and applying it to a different body part. And a good thing we always try to do is like a test retest to see, okay, is this technique good for you? So if a patient says, oh, it hurts when I try to reach behind the back, and maybe we do some of these contract, relax techniques to try to lengthen that, and then have them reassess that motion. And if it was better, we know, okay, maybe that is a valuable technique to do. Okay. So yeah, I think as long as we test and retest, that gives us a good example of, okay, this is good for the patient, and then that is a buy-in for the patient too, because they see results, so they're going to want to then follow through with some home exercise that you might prescribe.
Okay. In your general approach, so we'll shift gears a little bit.
Yeah.
So in your general approach, do you feel like patients get more benefit by coming to you for like a long period of time? Say for 12 weeks they come in 2 to 3 times a week, or is your approach more to kind of teach them the exercises and get them independent as soon as possible, or do you feel like some sort of hybrid in between model is the best approach?
A little hybrid, but again, it's kind of individual, definitely, because when you can pretty much tell right out the gates if this person is motivated and willing to do whatever it takes to get back to normal. And sometimes that can just be, okay, these are the 3 best exercises. You're going to do these. I'll see you next week and we'll reassess. Because often I think we might give too many exercises, and then if something flares up, we're not sure which one might have caused the problem. So I like to take the little sniper approach and maybe 2 or 3, make sure they do it right, and then have them come back and reassess. So I feel like I'm a little bit of a failure if they're coming for 12 weeks. For 3 times a week, I feel like, you should be independent by now.
Okay.
But it is based on, like, somebody came post-operatively, they might need that.
Oh, yeah.
But if it's something where if physical therapy is going to work and we've honed in on the cause, they should see benefit in 3 to 4 weeks.
Okay.
If not, we're maybe going down the wrong path.